I'm so grateful to be here because this is a data analysis and project that I'm like very personally like jazz hands about and very invested in and really excited to talk to you about. Okay, just for some context, Alana Kalinowski, she, they. I am a social worker and have been a part of the kind of founding team of the Community Information Exchange at 211 in San Diego. And we also belong to with our local HIE, San Diego Health Connect. And so within the kind of, conglomerate that we are, we get to do a lot of really cool things because we get to leverage our HIE for sharing medical records and really leveraging that technology to do continuity of care and share those medical records across systems. And 211, as noted, is really leading all of the work around maintaining this like living database of what is in our community, how do people find what's there, and like what's relevant to them. And that's really difficult to do on a lot of different levels. But I am coming from a CIE perspective, so that's what I'm going to be focusing in on real fast. Hold on. I'm setting my timer. I've met me. Okay. So don't worry, I'll shave off a minute or two. Okay, so who here has heard of a CIE? Okay, cool. So they look different across the country. When we first started the CIE, we didn't have anything to point to or look to yet. But really, it is for us, and I'll speak from a San Diego perspective, we are a legal network of health and social service agencies who have come together, and we use a interoperable platform that basically creates this longitudinal record to do care coordination activities, which is like the longest sentence in the world. But in real life, it has all these different kinds of care coordination functions, like closed loop referrals, like having care teams and showing like program enrollments and alerts for those care teams when really important things have changed in a person's life. And really all of this is meant to like drive the burden being taken off clients to be connected to the services they need and are trying to access in a time of need, but also knit together our wider system of care, which is structurally not knitted together, right? And so part of it is really trying to make sure that there's the kind of art and science of connection to services and giving access, and how do you have a community-led CIE that has governance and policy that protects people, recognizing that information of who we serve has been historically used against people and weaponized. And how do you also have enough meaningful information to make it so someone is not bearing the sole burden of accessing our very complicated systems of care? Okay, so how we do stuff, and I've worn like every hat you can wear with our CIE. I currently lead all of our data integration and interoperability projects, which is also how I kind of wormed my way into a lot of work around data standards with the Gravity Project and getting to look at like how do we codify and standardize data that talks about social care and social need. And I think there's a reason it is this emerging consensus building process, because the realities of our lives are complex and intersectional. And how do you identify when are these pieces of information really relevant for access and when are they not? And it's complicated. So I'm grateful to get to be part of that. And what that means is when I'm also driving kind of data integration projects, we're also trying to look at like what is meaningful like data sets, what are we trying to do to achieve what we're doing? Oh, I'm a fast talker, so look at that. I'm doing great. I've been here like almost 20 years, but I'm from the East Coast, so I feel like there's an explanation there. Okay, so this is my favorite thing we've ever done. So given this context, so CIE, it's this longitudinal record that looks at people over time. What programs they're enrolled in, but also recognizing that like when you're looking for help, you often have to get help in tandem, right? Like if I'm trying to start a new job, and I can't start my new job until I have secured childcare and transportation. If those things are not lined up in order, everything kind of falls apart. And anyone who's ever done anything with housing also knows this. It is like magic to get someone moved in. Because of so many things that have to be there. You need arrears paid. You need for deposit. You need like move-in costs. You need all these things to make that happen. And so often funding is not part of coming from the same funding source. So it has to be magically timed together. And it's really hard and difficult. And a lot of times, there's work that is really unpaid from like the services that are trying to do that work. The care coordination is typically not funded. And it's always like someone went above and beyond. And it's like, well, that's not how our system should be designed, but here we are. So this is a project we did, started in 2019, and honestly it started even before then. At the time, the leader of the Salvation Army, Paul Armstrong, and I, we'd been part of collaboratives here in San Diego for a minute. And there was, coming down from the state, one-time funds, HEAP funds, which was like homelessness, emergency, something funds. It's probably in here. This paper is on our website. Go to it. It's really cool. But basically, what happened was prevention funds are like real scarce. From a societal level, because we moralize poverty, we don't like giving money to people who are still housed. That's the reality. We also have kind of in the ethos, there's like three often like dominant myths that also really shortcut efforts to do prevention funding. And Paul and I, we were talking to a lot of the other service providers, housing providers in San Diego who had historically done prevention funds. And there's different sources of prevention funds that come down through HUD and different ones. And basically what the myth is that if someone is on the verge of homelessness, they're basically going to become homeless. That's one. If they are having a hard time paying, like basically they're going to figure it out. They're going to self-resolve. Well, that's another one. And then the other one, which was like a very programmatic one that persisted, was that you can't find the people who are actually eligible and specifically need prevention funds. So prevention funds, just from like a more like specific lens, prevention funds are for people who had been stably housed on their own and had an instance happen that destabilized them. They've exhausted all resources from, friends, family, any kind of funds. And if they had but one flush of dollars to essentially stabilize them, they'd go back to stably housed on their own. And if they don't, they will become homeless. That is like the kind of definition of programmatically, like who should get prevention funds. It's like a very narrow group of people. And like from a screening lens, that's like also really hard to define. So what we did was we said, okay, cool, there's these state dollars coming down, they're one-time dollars, there's a carve-out portion for prevention funds. How do we take advantage of this? And so all the providers in town, and it was like initially like 13, it ended up being 11 service providers across our county were like, let's take advantage of this. Let's show how powerful prevention funds are. And we'll use the infrastructure that is our community information exchange to show what happens. Because, and this is where I think interoperability is wicked cool, is, I don't want to give it away too fast, but basically, because we get to also integrate with our local HMIS and have data about who's enrolled in different programs and who is essentially hitting like HUD-defined homelessness coming into our database, but we also have all these other essentially data elements that look at not just this cross-section of instances of homelessness, but rather like the whole span of someone's experience. And we were able to like essentially look at like what happened. Did people end up becoming homeless because they interacted with the system of care, or did they stay housed? So we kind of had a cool study baked in. And basically what we did is we got together, we're like, okay, there's some existing screening tools about how to identify people. let's come together. We're going to create a agreed upon screening tool. We're going to build it in CIE. We're going to agree, unfunded, we're going to agree as 11 service providers in town. We're all going to use the same screening tool. We're going to take advantage of the CIE as where to like enter that data and do the screening tool there. And we'll do the closed loop referral functionality so that people are getting connected to basically the correct homelessness prevention funds. Because of course, there's the other layers of demographics. Like, I'm the San Diego LGBT Center, and I serve Central San Diego queer folks, whereas the San Diego Housing Commission, our housing authority in San Diego, they also serve the city of San Diego, but not specifically queer folks, right? So like, you have to also do the navigation to very specific providers. So we like came together, we got to go and built it, and we said, okay, let's do this. COVID also happened. Started in 2019, COVID started. Not to mention there's a whole host of other like variables from a data perspective, including like, we have other funds in the community that drop at different times, and it tends to act as like almost like a piñata, right? Like all of a sudden, like dollars drop in the community for different things, and so that can be tricky from an access lens. But basically, what we got to do was, and I'm going to show you the actual screening tool too to walk through it a bit. But we basically got to show that of the people who were screened and got money, versus the people who were screened and didn't get money. Of the people who got money, they were 15 times less likely to become homeless. Just like, when you think of all of the costs to not only like the actual, like if someone becomes homeless, the actual like resources, all of the like compound trauma, all of the odds that and like essentially risks of incarceration, SUD, like a whole host of other things that get layered on as soon as someone hits the streets. Like it's like this massive win to be like 15 times less likely to become homeless. And because the CIE is this like kind of longitudinal record, and we have all these different data elements, like they called for energy assistance or utility assistance, or they called for other things to basically act as essentially proxy data, as well as like very known data of like if they're enrolled in like a HUD-funded program or things like that. And my colleague Castle here was also one of the data analysts and co-authors of this paper. You know, we had to really get into this data, but it's basically able to show that, thank you, that after 90 days, it's 7 times still less likely, and after 180 days, 6.5 less likely to become homeless, which is like so cool. And to me, what that also speaks to, oh cool, there it is that like as a community, not only get to show the effectiveness of a program that has bad PR for a variety of reasons, but you get to show like the realities, and you get to layer on all your other studies of, okay, if someone needed prevention funds, what else did they need? For the people who didn't become homeless, did they access anything else? What did they access? For the people who stayed housed and got these dollars, did they access anything else, and was that part of what was that effectiveness? So there's all these other like additional things we're hoping to get to explore with the data, but like what we get to show as a community is like, no, this is how we get to allocate resources. This is how we get to think about moving upstream. This is how we get to think holistically and not from a very like structured cross sections of like instances of homelessness or people who are housed. And like the reality is we all have like continuum of lives, and they can't be like chopped up into these snapshots. And what's cool is getting to be able to show that also from coming together, like all these service providers, like it's a wholly unfunded activity. We just were like, no, we know this is powerful, we know this matters, how do we take advantage of this like existing infrastructure to do it? So I have this in here because one of the things from my soapbox for interoperability pieces, a lot of times the data sets that, this is my one little preach moment, is that you know, we often are looking at important contact information, for sure, but recognizing that to access services, you frequently do need other types of information about people, because that's how service providers are funded. And that's not new, everyone kind of knows this, but I'm just underscoring it here. So basically we go through and we have our little logic here, because we're trying to, there's our source on the left-hand side of like, what's the question already, and then kind of moving along. We're trying to really narrow down, like, have you exhausted everything? What have you tried? All of these kinds of things. And then you have also some population information. Again, this is also on our website. Because also we had to rule out, if it's an IPV situation, you're not a prevention fund candidate. If you are, like, basically if you've been too unstably housed on your own, then then like you gotta, like, you actually don't qualify. You gotta be able to demonstrate that you can go back to being stably housed on your own, which also, I'll just say, points to other kinds of services that should exist. But anyway, so this just goes through and really kind of getting at all the kind of key data that we kind of recognize needs to be able to be captured for us to effectively do this care coordination and demonstrate, like, this power of prevention funds. Okay, done.